Yeah, we got a lot.
Yeah, a lot to do.
Packing this bag.
You really have to be careful what you say, huh?
UW,
You're always recorded.
It started, 5 minutes, about 10 seconds ago. It just started.
15 minutes ahead of time. So, yeah. Sometimes I've been caught giving my political opinions. Get slapped on the wrist.
Oh, and the dirty jokes.
Boy, every day somebody new gets himself in trouble.
Oh, yeah, now I can see this snowballing, no question. Even when maybe we have to worry.
No. No one's interested.
No, that's right. Was the drive get a little wet? It's pretty nasty out there.
One block was enough to sit.
Well, being dark and the rain and reflecting light, it's always a little bit more. I know, I agree. I don't have cataracts yet either.
For the road.
Len had his out after ask. Can you tell the difference driving at night when it's rainy with their cataracts out?
Oh, I couldn't drive. It was dangerous. I see these big halos around lights.
Yeah, I know. It was tricky today. I don't think I have any cataracts, but it was. At least I know that road. I've got it memorized. I was driving over here 1,000 times. So. But it was nasty drive.
In Hawaii, I actually gave up nighttime driving. I was
Just
just
because of that.
drive because it's so dark over there. And it was just, I think we have double orders of food again.
Oh!
Okay. That's
Nobody
fine.
goes away.
Just somebody take it home with them.
I'll take some of it over to Redmond. I guess we'll take some. If you want to take some back to your office.
Oh, I'm just in Kirkland. There's nobody there, so.
There'll be somebody at the door, and then just head past the front desk and take a left. It'll be down that way. I'm sorry to see.
Yeah.
Been coming for a year now. I have never noticed the wall.
This is the first time I've ever seen no wall. Oh, you didn't know it was a removable wall?
Yeah, no, it's normal.
Expecting a bigger rock.
I knew it was a removable wall, but I've never seen it not there.
When I walked in here the first time, I was like, whoa!
Okay, just a little reminder that they'll be getting it as soon as they have it already.
Okay, thank you. Something else.
Oh.
Morning, Mary. How are you?
I'm wet. How are you? It's nasty out. Nasty.
Just used to sunny weather around here. This is unusual.
Like Humphrey Bogart in Casablanca. Why you moved to Casablanca for the
Morning.
it's a weather-related line.
I'm not showing us the status.
That was moving for the weather. I don't.
I'm already kind of there.
I started my day by falling completely out of bed. Like,
Is weather nasty there? Is it supposed to be
All over the
nasty?
floor.
my son was like waking up from a bad
It
dream.
would be nice.
No, the alarm went off and I don't know. It's like I'm at the house like
Watch
a
the
relief.
movie again. I'll let you know
Like,
next week.
threw me off and
I don't think I watched the movie all the way through until about 3 years ago. When you start from the, I'd always see it,
I'm glad I
I forgot the whole
get on that.
gist of it.
You know, like,
Watching it
oh,
again,
nice.
it's a
Oh
great
yeah,
movie.
that was
It's a great movie.
workers' comp issue today.
Well, it's a complicated plot. Of course, the French were actually, the Germans dominated them and had Vichy government and all that. And it's all confusing about the interaction.
Well, that's why he drops the bottle of Vichy water at the end of the movie.
Yeah,
Remember, he shoots the German colonel, and Bogart does. And then the line, he calls the guys and he says, round up the usual suspects.
Yeah.
And then he's got a bottle of Vichy water and he drops it. in the
Symbolic.
car. Yeah.
Very good. I missed that one. I have to go back and watch it again. Like I said, I've only watched it all the way through
My
once.
medical
so.
school roommate got me into Bogart movies. We used to go to the Brattle Street Cinema over in Harvard Yard, Harvard Square. They'd have Bogart festivals, and I sort of fell in love with that movie. Oh wait, I moved here for the waters. We're in the middle of the desert.
Oh,
That's
that's
the
it.
line.
Okay. We're still working on the date. It was a 50-50 split on
I
that.
saw that.
You know, so we're going to try one more date in between. When do you leave for Hawaii?
The 11th.
Yeah, you might
I don't
cut out.
think
Yeah. When do you get back?
Actually, this year we're coming
I can't
back
call
on
35
Christmas
for
Day, because somebody wanted to rent our house.
It's like cold.
And since Wayne's
Majority to
Sorry.
the reviews, and, you know, I've been.
So you can't call it perfect
Oh
cold
no,
either.
I've really acclimatized. I think if I went home, it'd be like
I grew up
cool
in
runs.
Chicago, and I'm
No,
like,
I don't think.
I haven't even busted out like
You were going to probably try middle day, but you know, this is getting complicated now. So.
Oh, you're gonna have the boat this weekend?
Yeah. You want to football? Oh, that's right. Come down and join us.
Yeah, we have tickets, our newest junior faculty. She just moved from the Bronx.
I heard that last night.
All right, well, we'll get there probably at 5 o'clock p.m. We'll be there around 2.
Nice to be in the
Really?
same
I get
place.
there early.
Well, we're,
You have to change your
someday,
7 o'clock kind of thing. There's no problem. Usually at work anyway.
usually if they have a they go.
Husky rowing shell house 2 hours early.
Yeah, you know where that is. Well, you know what it is.
So we'll be there probably 2:30 or
That's farther north than we are, but we're close by there, so. No, you should go there. No, it's fine. I had never been in that new.
Yeah.
That's pretty impressive. Yeah, it's very impressive. Very nice. Got the shells up on the ceiling.
Oh, yeah.
one of the classes.
That's our, where we go.
I looked at the forecast and it's gonna rain. Little amount.
Well, it is like a race course or something.
Yeah.
I think it's supposed to be rainy though. That's one thing good about the boat. You can stay
Roll the dice
inside.
and travel.
Yeah, get where
I don't know
shelter.
whether it was southern part of the stadium where we would be sheltered.
If you're in the really high rent district, yes. You probably are. Yeah, you probably are.
No one's
I don't
taking
know.
No, yeah, my parents.
No, you're not a sports fan, but this is, he's a big sports fan. He's a big customer.
I've been going to the game for 50 years.
So this
Call that
weekend
big
is,
fan. This was the Washington
yeah, this
State.
is coming up the interstate.
Also,
We were
Two teams are ranked almost dead heat.
right. We followed. We got to 4 last year. We played in the playoffs, so we were really good last year, but we're just a man short this year. So we're already knocked out. But you don't like to live in plus we're at home. Helpful for us. There's definitely a big deal.
Still got a lot of left.
Out
there.
Another speaker that one when you were out at dinner.
No, I mean, he's talking about the Seahawks lost.
Oh, that's what they're called, the
I went to
Seahawks.
dinner last night at the restaurant.
I feel like I'm a failure.
It's an exciting game. These five of them trying to climb back. I got to coach this awkward decisions there.
Yeah, I just started watching that close.
Listening to it talk. Was he talking?
No, we were just drinking.
Okay. Anyhow, you don't want to watch it.
He's one of the young, Drew, no, Dr. Zuraw.
Yeah.
He was on part of the Heirs Connect.
That burn ran with the kids.
I think it's working.
Okay.
Are you a bird watcher?
I just got back from a trip to Africa, so I'm going to show a few of my pictures.
Got your lilac-breasted rollers.
It is indeed.
He's pretty big into
Well, I'm
all kinds of it.
No, I don't bird at all. The only time I ever bird is when I go like to Africa or someplace exotic like that.
It's
So
fantastic.
you looked at that picture and knew immediately what it was?
Yeah.
Oh, that's a classic.
It is one of the most beautiful birds in the world. They're all over the place there. No, the only place I bird, I can't tell little brown birds. But in Africa, the birds are so There's no problem. I know, I know I'm not.
The trick is to catch them with drones, because they're fast.
Yeah. Oh, no question. You got a good camera. You took that picture. That's very good. Yeah.
I wish you could come up sometime.
Birds are spectacular. Kingfisher, is so brilliant.
Yeah, I know.
You know the one I'm talking about. I'm trying to
Well,
think
there
of
was like 10 different kingfishers.
and they are all different, little tiny thing, but just brilliant blue. Its name has something to do with the blue of our fly.
I caught a picture of one kingfisher just at the top of his dive when he was about to, he was just turning, and it was so far away.
I didn't have a fancy camera. This is why I fancy camera. But we're in the Galapagos, and the booby birds were diving, and one of the guy got a picture just as a dart, and it's just as big, just as a dart. His body goes from this wide to that wide, and he just caught it.
Baby and all?
Oh, yes.
Oh, yes. Oh, that's amazing.
That's another good place to bird watch.
Yeah.
Have you been there?
I have not been there. But I've been reading that. I live in the city, the amount of animals is like 4
Yeah, you better get down there. The turtles, actually, the turtles are there, and they're protecting them pretty well. You know what the biggest thing was they get the rats got on the island, the turtles got on the island. They got rid of most of that. They have each island has its own subspecies of turtle, tortoise. One of them is extinct. There's the last one lived about 125. Lonesome George. Anyway, it's a great. Yeah, that's right. Anyhow, how many islands? Well, it depends on our trip was only 5 days. We did it with Machu Picchu, so we were there first there. But at any rate, you can stay 2 weeks. And the number of islands, unfortunately, the number of days. We were on, I think, 4 islands. That was a good trip. Yeah.
Too bad. $50 for it's two of my friends. Yeah,
How are you? Good. How you doing?
I don't know. I see you.
I saved it for you. Or was that yours? No, no, no. Over here.
What a witty bunch.
Angioedema.
I can spell that for you.
Maybe two, but it's not. I think he's going to wake us up before the fall.
These days I could get myself in trouble, right?
Well,
Only if it's you.
It's not. I'll put that right out as well. Just don't make me have to prove it.
Wedding.
Eat up, everybody. We got 2 orders of food today. I don't know what I'm going to do with all of it.
Thursday morning, in fact, they were talking about me riding with you. Are you going up Thursday morning?
I did, yes.
I know, I guess the car's too small. No. We talked about that. I'll go on my own car. I was trying to get leaves.
I'm so white.
Like you could just that would be tough. And a car. You didn't know it.
I was about to ask if you were going to go to Cali for Thanksgiving, but no.
Bad decisions by the coach. What else? That one, if they can go that far out, and a chance of him skipping time. And then taking the time out when it's clear.
Oh,
Yeah.
that's scary.
I thought it was good.
She went well, right? She absolutely trusts us. I was like, yeah, we're not this time. I recommend it. Yeah. Yes.
Got the rat lately.
Yeah. It's really, I'm trying to go visit my son in California for 3
Well, right. For a couple of months.
Couple months, yeah.
Yeah.
I know where you were.
Not till after Thanksgiving. So,
I don't know, I just, the first one, there was another federal thing.
well, he's outside of San Jose. My daughter's down there too.
She in the
Los
Bay Area?
Alamos. She's Los Altos.
How are you?
All right, let's everybody take a seat. And as I said, there's plenty of food here, so feel free to take some to the road. The word of the day is cleverly angioedema. And it's really an honor for me to introduce Bruce Zuraw, a longtime friend and literally world expert, certainly American leading expert in this disease. Also, I thought he should come up here from San Diego for a little weather reality, so he didn't get too much sunshine and warm. So thanks very much for coming. He's going to give us a really cutting-edge update on HAE.
Thank you, Len. It's been 4 years since I've been here, and I like a dose of reality once in a while. Well, we did have a wet winter last year, finally, in San Diego. And what I'm going to do today is something probably I shouldn't do, which is I'm going to try to multitask. And so people who don't care about my angioedema, I'm going to show you some pictures we took on a recent trip to Africa. So maybe you'll at least enjoy part of the talk. This, as we've already discussed, is a lilac-breasted roller that I caught as it was taking off in Botswana. And here are my disclosures. I do have a number of disclosures, but I like the, you can define conflict of interest different ways. And this cartoon tickles me. And what I'm going to do today is I don't have that much time, so I decided to focus on three areas. The first is for those of you who aren't really, I know there's fellows in the room, so I'm just going to give you a very brief, very simple background in hereditary angioedema. Then I'm going to talk about some of the developing new drugs and how the treatment of HAE is in flux and where I think we're headed. And then I'm going to finish with the area that's driving most of us in allergy immunology crazy, which is the HAE normal C1 inhibitor, which some people term HAE type 3, and I hope I convince you that that's not a good term for it. So those are the three things that I'm planning to cover. So this is basically your introduction to hereditary angioedema, and hopefully everybody already knows this, that the hallmark is recurrent angioedema without hives. If you see somebody who fits that pattern, please order at least a C4. It's a simple test, and you won't miss many cases that way. It's rare. The prevalence is really honing in on about 1 in 50,000, and as far as we can tell, across the world, there doesn't seem to be any significant difference in different ethnic groups. It certainly affects men and women equally. It's autosomal dominant, which goes along with men and women being affected at equal rates. It doesn't skip generations. The penetrance is rather high, so patients are only rarely asymptomatic. And it's been said to have about 25% of the cases being a de novo mutation. As we were talking at dinner last night, I just got back from a meeting in Frankfurt where there was a poster, a abstract presented from a group in Europe where they looked at one of these de novo cases and then they carefully studied the sperm of the father and found out that he had genetic mosaicism. So that, maybe it's not de novo as often as we think. Nobody really does that. So you might want to keep that in mind. The attacks are very they tend to be stereotypical. Like anything else, it varies. But the standard attack is that the swelling worsens slowly, not rapidly like anaphylaxis, slowly worsens for about 24 hours, hits a peak, and then takes about 2 or 3 days to remit. And that's the 3, 4, sometimes 5-day attack. The most important thing that physicians need to know is in red here, which is that it does not respond to standard therapy. You can give them antihistamine, steroids, epinephrine, and it is not going to change the trajectory of the attack. And so that's how patients under care die, that they go to the emergency room, they're given the usual cocktail, sent out, and then they collapse and die from asphyxiation. And of course, there's considerable morbidity and mortality that can be associated with the disease. And the disease affects the extremities, the genitalia, the face, the abdomen. In confusing cases like HAE normal C1 inhibitor, we often image the abdomen now because you should see thickening of the bowel wall if it's really angioedema. This is the gene that codes for C1 inhibitor. It's SERPING1. And the point I want to make about this is that the mutations are scattered. There's now more than 400 mutations described. This is a little bit old. It's scattered throughout the gene, but
There is a pointer on the,
oh,
is there a mouse yet through, or?
There you go.
There you got it.
okay. I have to make myself small to see it. Right here in exon 8, in this magenta color, that's where all of the type 2 mutations are clustered. With one exception, there's one in exon 5. But the reason they're all there is that codes for the reactive mobile loop, which is the substrate for the proteases, where proteases attack C1 inhibitor. And if that's mutated, it doesn't attack the C1 inhibitor, and the most trap doesn't spring. And so that's why type 2 is dysfunctional C1 inhibitor, and all of the other mutations lead to a failure to secrete C1 inhibitor. I unfortunately don't have time to talk about it today, but a lot of my research now is centered on the fact that, okay, you have a mutated allele for SERPING1. You still have one normal allele. You would think you'd make 50% of the normal amount of C1 inhibitor, and as I'll show you in a few minutes, at 50% you don't swell. So what's going on? And if you measure functional C1 inhibitor, it tends to be about 10 to 15% in untreated patients. And so we think that the mutated protein is acting in a dominant negative fashion, affecting the wild type C1 inhibitor. And it's a very interesting therapeutic opportunity because if we could rescue the wild type, maybe we could come up with a much cheaper, much better form of therapy. But I'm not going to have an opportunity, unless you want to ask me about it afterwards, to discuss it. This is data that I think is important from Konrad Bork in Germany, looking at 131,000 attacks and looking at where do the attacks occur. And if you say per episode, you can see that extremities and the abdomen are about neck and neck, and all other locations are quite minor. But if you look per patient, the important point is shown here that laryngeal angioedema is described in more than half of the patients. Every time a patient has a laryngeal attack, they could die. And historically, we've thought that 30 to 40% of patients with HAE die from laryngeal angioedema. And unfortunately, we still have deaths even to the current time in the United States. So you have to really approach these patients thinking no matter whether they've ever had a laryngeal attack or not, no matter how mild or severe the disease is, they could potentially die. And the burden of illness is quite high. So I've just mentioned the asphyxiation and death. Abdominal attacks are really severe. We were at an FDA meeting. The FDA had a public meeting allowing patients to testify this fall. And woman after woman got up and said, you know, childbirth was like nothing compared to my abdominal attacks. So it's a really severe pain, a lot of nausea and vomiting. Most of the older patients have been operated on with normal findings, and then a number of patients got addicted to opioids. Some of the HAE deaths were from opioid addiction. It was a real problem. Luckily, modern therapies, I hope, have interrupted that problem. If you ask patients, how does the disease affect their life? This is a little old now, so luckily it's changed, I hope. So this is 457 patients published in 2010. But 100% felt that the disease had an adverse effect on their school or their job. If you just asking about the last attack, which may have been a very mild one, 50% of them said they missed school or work because of their most recent attack. They were missing between 20 and 100 days per year from work or school. And then the unpredictability, am I going to wake up in the middle of the night with my throat swelling, causes tremendous psychological pain, and a very high percentage of these patients are depressed. They have very high anxiety scores. It's really quite disruptive. Luckily, the diagnosis for HAE due to C1 inhibitor deficiency is as simple as it can be. Just a couple tests will get you through the whole process. If you have low suspicion, I tend to just order a C4. If it's normal, you've largely ruled out a C1 inhibitor deficiency. There's a couple percent, particularly if they're taking androgens or taking medicine, that it could be normal between attacks, so then you repeat it during an attack, and if it's still normal, you've really excluded C1 inhibitor deficiency, other than a case that Len and I shared. That's always stuck with me, but that's really exceptional. And if it's low, you can get to the diagnosis by measuring C1 inhibitor antigenic levels, which will be low in type 1 HAE, which is 85% of the HAE patients. The other 15% have type 2, so they'll have a normal antigenic level, and you have to measure the function, which that's a little bit problematic in that when you order C1 inhibitor function, you almost certainly get the Quidel assay, where normal is greater than 68% of normal. And that test is not a very good test. At the Angioedema Center in San Diego, we're now sending our samples to National Jewish Complement Lab because they're the only people doing the chromogenic assay for C1 inhibitor function. Our clinical lab has agreed to start doing it, so I'm hopeful in the next few months we'll offer it as well. But just so you know, if you think somebody really has type 2 HAE, and the function is normal, send off a chromogenic assay.
If that on the lab test, it also comes up with measuring C1Q. I find most labs do a total C1 as opposed to a C1Q. Is there I guess you could send it to National Jewish. That's the only place I know.
Yeah, I think that C1 and C1Q will give you, in my opinion, about, as long as we're giving you the level, are largely going to give you the same results. The problem that I see is most people ordering a C1Q, you get a C1Q binding assay, so you're getting an old measure of immune complexes.
Which is where it's often tricky, because if you send a C1Q, that unless you send it to National Jewish, I think that's what you're going to get, as opposed to a C1Q.
I often call the lab when I do that and explain it to them, because you're right, they make that mistake repeatedly. This is some data about age of onset and age of diagnosis. And let me make a couple really simple points. The first is it's a pediatric disease. Virtually everybody starts swelling before the age of 20, and half the patients or so start swelling by the age of 10. But then on the right, if you look at the age of time of diagnosis, you can see that the peak is around 20, and there's lots of people between 20 and 40 who are diagnosed. And on average, we're seeing about a 10, even though it's genetic, even though you would think you'd pick it up shortly after birth, we're seeing about a 10-year lag between onset of symptoms and diagnosis. And I would say that the pediatricians are not paying attention to this disease. And this was the first year ever when I heard that a question about HAE was on the pediatric board exam, which I thought was great because that's what will cause the residents to pay some attention to this disease. And the reason it's so important, well, I'll get to that in a second. This is another part of the study that we published about pediatric HAE. And the amazing thing here was we regressed the delay in diagnosis against the age of first symptom. And what we found was the younger the kid was when he or she started swelling, the longer the delay to diagnosis was. Again, suggesting that the pediatricians aren't thinking about it. And let me go back to Conrad Bork, because he looked at his data, and what he found was he looked at mortality rate, and you can see the mortality rate is hugely higher in patients who don't have the diagnosis formally made than those who had the diagnosis made. And the mean age of death by asphyxiation was only 41 years. So these are relatively, to my perspective, very young people dying really unnecessarily. So the real key for our colleagues who are not allergists is think about the disease. You know, when you talk to somebody referring to a patient, or if you're talking about angioedema, if you see somebody with recurrent angioedema without hives, just order the C4 and we'll be a lot better off. So when I talk about therapy, I'm going to assume everybody agrees with me that bradykinin is the mediator of swelling. This was my entry into the field in the early mid-'80s when it was highly controversial whether it was C2 kinin coming from the complement system or we said it was bradykinin from the contact system. And I think it's really established now. And I just wanted to take you through a little bit of the data quite quickly. So there's ex vivo data, and I'm showing you two bits here. On the left is a plot for kininogen cleavage, high molecular weight kininogen cleavage that we published, showing that during an attack, kininogen is cleaved, releasing bradykinin. So it correlates with the attacks. By contrast, C2-kinin has never been measured in vivo. There's no evidence that C2-kinin actually is generated in vivo. And a number of years later, Al Davis's group did a very simple, but I think really elegant experiment where they said, you know, we can make any plasma C1 inhibitor deficient. They just used an antibody to pull out C1 inhibitor. And then they said, well, if we pull out C1 inhibitor, the plasma will behave like HAE plasma, which is if you just let it incubate at 37 degrees, it will generate a permeability enhancing factor, whatever that is, bradykinin or C2-kinin. And then they said, well, if we can do that, we can use plasma that's either deficient in C2 or plasma that's deficient in kininogen, and figure out where the permeability enhancing factor is coming from. And sure enough, if they use C2 deficient plasma, there's no C2, you can't have C2-kinin, you still got this factor. But if you used high molecular weight kininogen deficient plasma, there was no permeability enhancing factor. And that was really, I think, a beautiful demonstration. And then again, Al Davis got his hands on a knockout mouse. This was a gene trap mouse. So it was totally deficient in C1 inhibitor. And what they showed is if they injected Evans blue dye into the blood of this mouse, that it leaked the dye. So it had a continuous permeability defect. But if they replaced C1 inhibitor, or they crossed the mouse with a mouse that lacked the B2 bradykinin receptor, in either case, the leakage stopped. again showing that the defect that led to leakage or angioedema in humans is due to bradykinin. And then finally, we got human data directly showing that bradykinin is generated. And so this was a paper by Nussberger in the top left, where they measured bradykinin levels at the site of swelling and simultaneously on the contralateral arm, and showed that whenever they did that, bradykinin was higher close to the site of swelling than on the other side. But in a way, the ultimate answer came from once we developed drugs and we could treat patients. So in this case, I'm showing you a bradykinin receptor antagonist, or a contabant, and that it vastly shortened the length of an angioedema attack. So you combine all of this evidence, and I think it's quite clear that bradykinin is really the major mediator of swelling. So this is in Rwanda, actually, and I was thinking maybe I'd join them for a snack, and the juvenile seemed to think that would be okay. The mother was not sure that she wanted me to join them, so I actually didn't get any closer.
How close were you?
I was about 10, 12 feet away from them. I'll show you another picture soon, a lot closer. Okay, so if we now all agree that bradykinin is the cause of angioedema, I'm going to transition now into where we are in the treatment. And 10 years ago, there was a revolution in the treatment of angioedema because people finally accepted that it was bradykinin, the pharmaceutical industry made drugs, and all of a sudden, we had C1 inhibitor replacement. Now, C1 inhibitor will inhibit both active factor 12 as well as active kallikrein. And so normally, 12 is activated to 12A. It activates pre-kallikrein to kallikrein. Kallikrein cleaves high molecular weight kininogen, and the bradykinin that's released binds to the B2 bradykinin receptor. So C1 inhibitor inhibits 12A and kallikrein. A kalantide or kalbitor is a specific kallikrein inhibitor, and a contabant or Firazyr is an antagonist at the B2 receptor. So we had these drugs, and for the first time, we really had good, specific, safe ways to treat HAE. And despite the new drugs, this is data that we published just from a patient survey at a HAE Association patient summit where we had like 500 patients there. And what we asked them is how, we assessed how the disease was at this point compared to before these drugs were available. And, you can criticize the study because it was retrospective. But basically, we showed that people felt like they were doing much better on multiple domains until you look at this graph really carefully. And what you see is two things, I think. Number one, yes, people improved. The downward slope would suggest the fact that they're below that line with no change, right up here in the middle, shows that there's change. But they went from like severe to moderate or moderate to mild. They didn't go from severe to doing great. And the other thing to pay attention to is this marker, which was their fear of having children. That barely changed at all, which really tells you that they still felt that the disease had a major impact on their life and they weren't eager to pass it on to their children. So I think the take-home message I got from this study was, yes, things are better, but they're not good enough. So I'm going to spend a minute or two talking about my bugaboo, which is androgens. And I've done a personal 180-degree switch here because I used to force patients onto androgens, and now I don't put anybody on androgens. So what I'm showing you here is a paper we studied about the efficacy and tolerability of androgens. And it turned out that our group of about 650 patients, we divided them in two. There was a large group who had previously been on androgens but decided to stop it. They're in the purplish color. And those who continued on androgens are in the blue color. And the total group is in black. And you can see that we just said what percentage of patients cumulatively had 0 attacks per year, 1, 2, 3, etc., up to greater than 12 attacks. And you can see that patients are still having quite a few attacks, and that the patients who stopped the anabolic androgens were doing worse than the patients who continued. So that seemed to be a factor in why they stopped androgens. And when we looked at the tolerability, they had side effects at equal rates. It was that it wasn't as effective, so they decided to stop. And then what we did is we compared it to the data. This is now, again, open label data for Cinryze, or plasma-derived C1 inhibitor, showing the long-term efficacy. And then, because I had the primary data for the Cinryze, and well, both of the studies, I could superimpose, even though they were different studies, I simply expressed it in the same way. And you can see that at every single attack frequency, a higher percentage of the plasma-derived C1 inhibitor patients had that number of attacks or less. So the cumulative percentage of patients who had that number of attacks or less was always higher with C1 inhibitor, but it also shows you that plasma-derived C1 inhibitor itself is far from perfect. And when we looked at the tolerability of anabolic androgens, again, here are the two groups, the discontinued and the current, and a whole range. I'm not going to read all of these. I don't know that you can read it on the slide. A whole range of complications, some serious, some just huge nuisance. There was a tremendous number of patients, and I used red lines to show you the ends of where each of these bars ended. So the percentage of subjects, usually around 50–60% of patients, had virtually all of these side effects. And it wasn't really that different between the two groups. And it correlated with the dose of androgen. So if you do use it, please use the lowest dose possible. But its side effects, when you ask patients, are really very widespread. We just published an article recently where we looked at comorbidities with androgen use. We entitled the article, "Androgens Not So Cheap After All," because what we find is that patients on androgens have more comorbidities than patients not on androgens, and those are very expensive. They tend to be lifelong comorbidities. And for every 33 milligrams of danazol that you're on, you have another 12% risk of having a comorbidity. So it's not a trivial increase.
Why do androgens work?
Well, I'll give, my answer is I don't really know. The official answer that everybody gives is that it stimulates C1 inhibitor synthesis from the liver. I would say we don't really know if the liver is the major source of C1 inhibitor. In fact, there was a very famous patient who had a bone marrow transplant done for Evans syndrome. He also had type 1 HAE, and after the BMT, his C1 inhibitor levels normalized. So think about that. I mean, everybody assumes it's the liver. And number two, there's no direct evidence whatsoever that androgens stimulate C1 inhibitor synthesis in any known cell type. I spent many years stimulating cells with androgens. I never saw any direct effect. People have given animals androgens and then cut out the liver and measured C1 inhibitor levels in liver cells. They can't show any increase. A French group said that, well, androgens are increasing kinase levels. so that if they break down bradykinin more rapidly. Maybe that's correct. I think that the honest answer is I don't think anybody knows why they do.
I had a patient years ago who was, danazol didn't work, and finally we had to settle on oral testosterone for Michael Frank's recommendation. And I thought I'd try to be clever and see whether injectable testosterone would do it. It didn't.
No, you need the 17-alkylated type of androgen. So injected testosterone is not 17-alpha alkylated, so it's not, it has no anabolic activity.
So why the difference?
Well, if I could answer that question, I could have answered.
Well, I just thought since they're so similar.
But the difference is the 17-alkylation, alpha alkylation, which is necessary. So all of, methyl testosterone will work, but testosterone won't. Stanozolol, danazol, you name it, they're all 17-alpha alkylated. So now I want to move into a couple new drugs. This one, maybe you're probably already aware of. This is subcutaneous plasma-derived C1 inhibitor. The trade name is Haegarda. When we designed the phase 2 study, which is what I'm showing you here, I can remember when the scientific steering committee was meeting and we were seeing this data come in, because we were looking at different doses one after another, and it felt like we were dry labbing, because here we're comparing the observed C1 inhibitor level to the modeled trough level, and at each dose it was dose dependent, and they absolutely lined up, so that it was a very reliable way of delivering C1 inhibitor is to inject it subcutaneously. And on the right, you see a regression looking at the observed versus the predicted C1 inhibitor levels in 2,000 individual measurements. And you can see we essentially have a line of identity. The ability to model levels of C1 inhibitor, if you give it subcutaneously, is quite high. And the reason I think that's so important is that I think we're going to evolve to the point, the dogma has always been, once you diagnose C1 inhibitor, you never measure the C1 inhibitor level again, because it doesn't tell you anything. But with this, I think it's going to change, because we may be able to start treating towards a target. Okay, you're not doing well enough, let's check your functional level. Okay, we have to just adjust your dose in a certain way. And I'll show you data in a couple minutes that will support that.
What's the frequency of administration with that?
Twice a week as well, subcutaneously twice a week. And so because the modeling was so good, these were the company scientists who developed the actual mathematical model. We modeled different doses of the subcutaneous versus IV plasma-derived C1 inhibitor. And for the IV, that Michael Frank had once termed this the shark tooth pattern. And that's the classic pattern where you inject it IV, the level goes up, and before the next injection, it essentially comes back down to baseline and goes up and down. And there, you can see there's a horizontal line at 40% of the normal level. So you have to keep that in mind. Why 40%? That's old data from Peter Spa going back to the mid-1980s, where ex vivo and to a lesser extent in vivo, he showed that at right around 40%, the complement system becomes dysregulated, so that the C1 inhibitor isn't present at a high enough level to control these proteolytic systems. So as we designed the study for CSL 830 or Haegarda, we were trying to make sure that we were getting above 40%. And you can see both the mean and the 10th to 90th percent confidence interval based on population size, how the modelers looked at 1,500 units twice a week, 3,000 and 6,000. And because of this data, what we decided to do when we designed the phase 3 study after we had the phase 2 data is we did go to a dose per kilo rather than a fixed dose, which is what we used, which is what Cinryze had used and what we used in the phase 2 study. And this is the data, maybe you've seen it, from the phase 3 study, showing that at 2 doses, 40 IUs per kg and 60 IUs per kg, that we got really great control of the C1 inhibitor. Median 89 versus 95% reduction in attacks. The attacks that did occur were sort of dodgy, if you will. You know, when you really go into the details, transient, fleeting, oh, a sense maybe my throat feels funny. People tend to do very, very well on this medicine. And if we looked at the reduction in treated attacks that needed to be rescued, let's say with Antibond, it was 100% reduction at the 60 IU per kg. So that just gives you a feeling for how good the improvement was. Now, unfortunately, as people in the room know, they've hit a shortage of the drug. They did not expect the uptake to be this fast, which is unfortunate, because I think this drug works great. And it did another thing that had been an argument in the field for years. And here's an instance where Mike Frank, who I think the world of, was actually wrong, because he always said that the C1 inhibitor level had nothing to do with disease activity. But we weren't using chromogenic assays, number one, and number two, we didn't have enough measurements, good enough data. So when we pulled all of the subcutaneous C1 inhibitor data together, what we could show, so that red line, that dotted line, the red around it is the confidence interval. So you can see how tight the data is. That we could show that the risk of having an attack was directly related to the functional C1 inhibitor level, which if you think about it, since that's the cause of the disease, it makes sense, but it was never demonstrable before. So it really says that we could treat to a target, that we can predict how well patients will do in general by knowing now the trough C1 inhibitor level. Interestingly, the clearance of C1 inhibitor turns out to be influenced by body weight, so that is in the model that allows us to predict, and the risk of having an attack varies with the patient's age. So the younger you are, the less C1 inhibitor you need to control your disease, and as you get older, you actually need slightly higher levels to have the same level of control. So there are lots of little nuances in there to consider. But this has really been, I think, a major advance. Now, the next drug I want to talk about is LanadaMap, which is a fully human antibody that recognizes plasma kallikrein, so active plasma kallikrein, and inhibits it. And so this data is the phase 1b study, which was published in the New England Journal. And what they showed is, number one, as you'd expect on the left, that it's a monoclonal antibody, so it has a prolonged half-life. And they didn't know whether to give it every 2 weeks or every 4 weeks. But, you know, like all monoclonals, it tends to hang around a long time. And on the right, they did some pharmacodynamic study looking at cleavage of high molecular weight kininogen. And when the drug was in the body, it prevented cleavage of high molecular weight kininogen, which means it prevents the generation of bradykinin. So you would predict from this that it would be effective. And the data that they published for the phase 1b study is shown here. In the top, you see placebo, where patients continue to have lots of attacks through what they called their efficacy window or efficacy period, when they gave 2 doses of the antibody 14 days apart, and subcutaneous, so they waited 8 days for it to reach the blood and reach steady state. and then they had this window of efficacy. And in the bottom, you see two different doses, 300 or 400 milligrams, and you see in that protected window, there was only, I think, one attack between both groups. So in the phase 1b study, it looked to be very effective. And now we know the results of the phase 3 study. This has been submitted for publication, but it was presented at the American College meeting this fall. And what they showed was data that, to my eyes, is very, very similar to the subcutaneous plasma-derived C1 inhibitor data. They get, like an 80 to 90% reduction in attacks. They gave the drug either 150 mg every 4 weeks, 300 mg every 4 weeks, or 300 mg every 2 weeks. And they did get the best results at the highest dose, the 300 mg every 2 weeks. But now they're trying to figure out how are they going to submit to the FDA for labeling. And the sense that I get is they're going to try to keep it wide open and let us basically individualize, because I think that some patients do very well at a lower dose, some need more, and we probably need the flexibility. I would say that all of these doses worked, although there was a tendency for improvement with a higher dose. And then if you just look at their various secondary endpoints, attacks needing acute treatment, moderate or severe attacks, or if they waited 2 weeks to make sure it reached steady state, all of these were very positive. So this is a drug that works well. And now we have an orally available kallikrein. That's a monoclonal subQ. There's a orally available once-a-day kallikrein inhibitor that's just finished phase 2 study and will be starting the phase 3 study in January. And this is just the design of the phase 2. It's just a simple parallel arm type of study. And this shows the pharmacokinetics and kallikrein inhibition or pharmacodynamic. And basically, they based their therapeutic window, which you can see over right here, really on how much kallikrein inhibition you get with C1 inhibitor. And you can see that it really took 125 milligrams to reach that window. And when they looked at the data, if you just look at all attacks, you can see that in Plum, you have placebo, and then 62.5 mg, which was predicted to be below the effective level, had essentially no impact whatsoever. Then at 125 milligrams, they had about a 65-70% reduction in attacks, highly significant. Then the interesting thing was, as they increased the dose, it got worse. And why was that? Well, if you look at abdominal, what they saw was, as you raised the dose, that patients had more abdominal attacks. Again, they're very strange abdominal attacks. They were really, I believe, GI side effects that people were starting to get some GI irritation. So the phase 3 study is going to use 125 and a slightly higher dose, about 175, and we hope that we'll hit the sweet spot. But patients are very excited about this because it doesn't involve needles, and I think it's going to work well. And the cool thing is, if you get below the needed level, if your level drops a little bit, they've made a liquid formulation of the same drug. They're testing that now in phase 1 studies in Europe to look to see, well, you just take it's absorbed very quickly. You just top off with a little oral kallikrein inhibitor if you start to have an attack, and we hope that that will take care of it. So I have a lot of hope for that. So let me just give you a really quick look at what else might be coming. I've already mentioned the monoclonal kallikrein inhibitor, and I've mentioned the oral kallikrein inhibitor. CSL Baron has a monoclonal factor 12A inhibitor. It's like the kallikrein monoclonal, except it hits factor 12. That's in early clinical trials right now. There are a number of companies that are looking at either siRNA or antisense oligonucleotides for either factor 12 or kallikrein. Some of them are moving forward, others they're still thinking about it. It's always hard to know if they're going to put their money where their mouths are. But like Ionis is moving forward with their antisense kallikrein, and other companies with the siRNA are making noise like they're going to move forward. I'm very interested in the concept of molecular chaperones as well as gene editing or gene repair, CRISPR-Cas, ZFPs, and ZPFs, however you want to approach it, and hopefully better, maybe improved CRISPR technology in the future. I think we don't want to be in the first wave here, but once the techniques are validated, HAE may be a really good way to go. And there's a company that's pursuing gene therapy, essentially adeno-associated virus, and they have preclinical data that suggests that it works very well. It's possible. There's no reason why you can't have a orally available B2 bradykinin receptor antagonist. Maybe there's some evidence that the B1 receptor may be involved. Maybe that will be developed. I don't know if we're going to see kinase induction, which may be the mechanism of androgens, but that's another possibility. What I'd like to leave you with in terms of therapy is that where we used to really favor on-demand therapy, the pendulum, the scales are changing, and we're headed towards the fact that most of the new drug development is prophylaxis. Patients prefer prophylactic therapy, and I think that's where we're headed. Now, I love this picture, and actually I didn't take it, my wife took it, because this juvenile gorilla, he's reached out and he grabbed her camera, and she snapped this picture as he's looking at the camera, wondering what it is. And you can see that's his mother, who started to get very agitated as they were playing tug-of-war with the camera. And the silverback, this 550-pound behemoth back there, couldn't have cared less. Just like humans, right?
Did you have a chaperone with a rifle with you?
We did.
Yeah.
But it wasn't for the gorillas. It was for if we ran into elephants in the mountain. Okay, let me quickly go through HAE with normal C1 inhibitor. Here's Bort's initial description in 2000. Karen Binkley in Canada described it at the same moment in time. In terms of differentiating it from HAE due to C1 inhibitor deficiency, there's a big gender difference. It's predominantly female. It tends not to involve children less than 10. So the average age of onset tends to be closer, to 20 or 20 to 30. It's more variable in the swelling, and people talk about, and it has characteristically more facial tongue swelling than HAE due to C1 inhibitor deficiency. And everybody focuses on estrogen worsening, but the same thing's true in HAE due to C1 inhibitor deficiency, and I don't think you can use that as a differentiating characteristic. The big breakthrough, we thought, was when a mutation in factor 12 was described in 2006. The problem that we've run into is that's only about 20-25% of the patients in Europe, and it's as rare as hen's teeth for some reason in the United States. So that didn't seem to be a very comprehensive explanation. And because it's in a part of the gene that doesn't involve the catalytic domain, it wasn't clear what it was doing to factor 12. But once we knew it was factor 12, we could study families, and what they showed was that unlike HAE due to C1 inhibitor deficiency, it was low penetrance, which adds to our problems when we're clinicians because you can't depend on the family history. In gray, you see silent carriers. And so this is a disease where you know that there may be a lot of silent carriers. And so it's very difficult, but it is autosomal dominant. And so we came up with criteria that frankly stink. We said recurrent angioedema without hives, normal C1 inhibitor in C4. You test them to high-dose antihistamines. They don't respond. And then either they have a factor 12 mutation or a positive family history. I just told you that both of those are unreliable, but that's the best we have, and it's led for all of us having tremendous problem making the diagnosis. We tend, in our own practices at the Angioedema Center, we use, once they meet at least the lack of response to high-dose antihistamines, sometimes we give a trial of omalizumab before we go on, but then we'll give them like some acantobant and see, do they have a durable, reproducible response to acantobant, and we use that in our diagnostic considerations. But we have a new test that I'm about to submit a manuscript that we've developed in my lab. This is the ROC, or the receiver operating characteristic curve. For those who aren't familiar with it, here's how you would interpret it. You can see the difference between a poor, good, or excellent test. So an excellent test would have an area under the curve of over 0.9, and ours is 0.946. So it looks like it's a very good test. We have greater than 90% positive predictive value and negative predictive value based on our patients. We had the diagnosis and the lab work completely separate into everything was done, and then we combined, we had a meeting where we combined the data. So we'll see if it's replicated in other populations.
What are you measuring? Or you're not going to tell us?
Well, when the paper is accepted, I'll tell you. It's not a very difficult test to do, and so it's potentially doable in clinical labs, I believe. This is near dusk one night, and we hung around. We actually had a glass of wine as we watched this pride lolling about, and then it got dark, and they took off, and we followed them as they went hunting. It was really tremendous fun. Okay, in the last couple years, a lot's been learned about HAE normal C1 inhibitor. This is a paper out of Sweden where they showed that the factor 12 mutant protein does not have spontaneous activity, but it's more readily activated by dextran sulfate. So that it's a disorder in which the contact system becomes activated too easily. And the question that they didn't answer is, what's the physiologic stimulus that may be activating it? And then this even more recent paper out of the Netherlands said, you know, if we look at the mutant protein as opposed to the normal or wild-type protein, plasmin can activate the mutant protein. So it suggests that maybe the fibrinolytic system could be a physiologic trigger in HAE normal C1 inhibitor. And then interestingly, this is not published yet, but it's in press, Conrad Bork and his group found a bunch of families, actually like 30% of their HAE unknown type, who had a mutation in plasminogen. So we're getting a very strong story here, focusing on the fibrinolytic system, being able to activate factor 12 and then the contact system in HAE normal. There's another mutation as well that's been described that's in press in Jackie, and this comes from Marco Ciccardi's group in Italy. And they found angiopoietin-1 mutation, the A119, the alanine to serine at 119. And this only involves a single family. But the cool part of this is the mechanism in that they showed that the mutant angiopoietin-1 can't polymerize. And if it doesn't polymerize, it can't bind efficiently to Tie2, which is its receptor, and Tie2 has a protective effect against the permeability. So in the absence of this mechanism, probably the endothelium is more susceptible to multiple vascular permeability enhancing signals. So there's a second family that's been found. It was actually found independently in Brazil, So this may be more widespread than just this one private mutation in Italy. So really a lot of movement in HAE. I just liked babies.
When you look back at the history of HAE, were these people always there and we didn't know it or did not?
I've asked myself that, how could I have missed it?
Yeah.
And I think they must have been, and I think we just dismissed them as crazy, which is what physicians do when they don't know what's going on. That's part of my editorial comment.
No, you're right.
Are those new genes being found through targeted sequencing of genes in the pathway, or is that from exome sequencing?
Exome sequencing. And the thing that puts us at a huge disadvantage is we don't have these 5-generation kindreds. And without that, it's very hard to do that. So they're just looking at mutations that co-sort with disease activity, and then post hoc, they're looking for a mechanism rather than targeted. We don't know a lot about how to treat HAE normal. Basically, there are 3 approaches: hormonal therapy, antifibrinolytic, or the treatments for C1 inhibitor deficiency. The first step, if it's a woman, stop estrogens. A lot of women get better if they're taking exogenous estrogens. That's simple. You can give progestin. This study shows that progestins can be effective in women. And there's 2 types. There's the anti-gonadotropic progestins, which are more potent, not available in the United States. But progestin-only pills like Micronor, 0.35 mg, that is available in the United States. And that was less effective, as you can see from table 4 here, but still effective. So that's something that you can use in women with HAE normal. I spent a lot of time talking about the fibrinolytic system, and in fact, one of our standard therapies is tranexamic acid in patients with HAE normal. That's the prophylactic treatment of choice for me if I can't give progestin. It's not perfect, but in general, more than 50% of patients tend to respond to this. So you could consider that. What about a Contabant? A Contabant also tends to work. Interestingly, it doesn't work quite as well in HAE with normal as it does in HAE type 1, but it does work, and we use it. On the opposite side, I see no reason to give prophylactic C1 inhibitor, and a lot of people are putting them on it. But it's quite funny that it's been acute use of C1 inhibitor has been shown to be effective some of the time. And here's a few references. The Bork reference found it was effective in 6 out of 7. Why would that be? Well, a long time ago, again in the 80s, we showed that during attacks of angioedema, when you activate kallikrein, you cleave C1 inhibitor. And Boulet in France looked at HAE normal and said, yeah, when a woman was swelling during pregnancy, her C1 inhibitor was cleaved. So you can imagine, during an attack, they may become temporarily C1 inhibitor deficient, and giving C1 inhibitor may work. So I don't think it's the best strategy. I prefer to give a Contabant, but at least there's a rationale for doing this. And I think that this is just a cormorant. I liked it because we surprised it, and as it took off, it clipped the water with one wing, and I like the little splash there. The last area is the idiopathic non-histaminergic angioedema. I just have this one slide. We use the response to antihistamines, maybe the response to a Contabant to help us distinguish it. I would not be surprised if many of these people are really HAE normal, unknown. We can't find a good enough family history to call them that. We treat them the same. In the test I showed you that we're developing, they're still abnormal in that test. So here's my final slide, how I classify angioedema now. I break it down to hereditary and acquired. If it's hereditary, I say, is it due to C1 inhibitor deficiency, type 1 or 2? If it's normal, Are there mutations or unknown? So type 3, what does that mean? We now have 4 different types of HAE normal. HAE12, HAE angiopoietin, HAE plasminogen, and then the unknown, which I think is going to be a smorgasbord of different mutations. So giving it one name doesn't make sense, and the mechanisms may be different. And then for acquired, it's either histaminergic or non-histaminergic. If it's histaminergic, allergic versus idiopathic, generally responds to our usual therapies that we all know about. Non-histaminergics would be the acquired C1 inhibitor deficiencies, the idiopathic non-histaminergic, which, as I said, many of them will probably turn out to be HAE with normal, and then the ACE inhibitor and other things like tissue plasminogen activator type therapy. There's some drugs that seem to cause probable bradykinin-mediated angioedema. And so with that, this is a carmine beet eater that I caught taking off. So I want to thank everybody for your attention, and I'm really delighted to take any questions you might have.
Hi, I actually have 2 questions. One is, how good of a predictive value is an abdominal CT scan not showing bowel edema to ruling out an HAE attack?
Again, because I like to try to drive towards answers, and I don't like to admit not knowing, I give it a high value if they're actively swelling. I just make sure that they're really swelling at the time. If they're having symptoms and it's completely normal, I weigh that very heavily against it being angioedema.
The reason is I have some patients whose abdominal swelling, definite HAE, sort of go on and are very typical, don't respond to Firazyr. And one thing Mike Frank suggested to me 15 years ago was to overtreat HAE, and if C4 is normal, everything's normal, CAT scan is normal, it's not HAE. Now, Mike Frank told me I was wrong with the normal CAT scan. I was going, ah! And so I was wondering if
It's hard to respond to.
yeah.
So we struggle with these patients, so you latch on to what evidence you have. It would not shock me if our sensitivity isn't as good as we think it is, but I roll that into, I pay attention to that.
It makes sense that it should be done.
Any other questions in the room? Yeah.
On your last slide, why do you separate the idiopathic non-histaminergic from the normal?
Well, because we can't show that it's hereditary. We don't have a family history.
So you're still insisting on that being hereditary.
Yeah. I mean, I think, words have to have some meaning. And if we had a better biomarker, maybe we could revise the terminology.
I mean, and what I'm curious on the relative prevalence you see of those different categories.
Yeah, I cut that. I had 1,000 patients from Ciccardi's center where he breaks it down. Now it's skewed because he's known as an HAE center, but if he had like of his 1,000 patients, 370 were C1 inhibitor deficient. He had about 300 who were maybe idiopathic, non-histaminergic, and a handful who were factor 12 mutation.
You started, and we all say 85% are type 1, 15% are type 2. Shouldn't we start revising that and into that 100% have to put in C1 normal?
I think once we know how to make a clear diagnosis, then we will. Right now, it's just guesswork, and so I would say nobody has a clue, particularly in the United States where we don't have factor 12 mutations, how prevalent HAE normal C1 inhibitor is, or how much we're treating a phantom.
Well, you appear to have a clue.
Well, but I don't know that our test, is going to be validated and is going to hold up. What we haven't done in our test yet is we haven't been able to get patients to come back get another blood measurement and make sure that if it's normal at one time, it stays normal. If it's abnormal, it stays abnormal. And quite frankly, I'm really looking forward to collecting that data because I'll be much more secure if it's reliable.
How soon are the new therapies going to be available?
LanadaMap, I expect to be out next summer. I think we're 2-3 years away from the oral kallikrein inhibitor and any of the knockdown therapies.
Some more questions in the room?
Yeah.
So we've had some difficulties of getting icatibant approved for patients with normal C1 esterase inhibitor. What's your way of getting it approved?
Repeat the question.
So yeah, the question is having trouble getting icatibant approved for HAE normal C1 inhibitor. And we tend to shade the truth here and we say, well, they have HAE, and we don't specify. And then, if need be, if they say, well, give us the lab values, justify it, then I basically say that I need to talk to the medical director, and I talk about the risk of death and that this is HAE and that it's licensed for HAE. And so it's unfortunately time-consuming.
And we've heard that C4 is not that sensitive for the diagnosis. And how often do you repeat? Let's say you're screening a patient, in the first visit I wouldn't do C1 esterase inhibitor. I usually send C4.
Again,
I think the question is how sensitive is C4 in picking up C1 inhibitor deficiency. So I think in HAE due to C1 inhibitor deficiency, the best data that I know is about 95%. But I think a lot of that 5% people who are on androgens, I think if they're off androgens, it's better than that, but it's not perfect. And so if I think that the story makes sense, it's not that often where there's a false negative and I think the story makes sense. But those cases, I always ask for a repeat during an attack. I send them with a note for the emergency room close to them so that we get it. Now, the other side of that is a case that Len and I shared in the 80s of an acquired C1 inhibitor deficiency who put the fear of God in me because this is a woman with terrible disease. And we studied her. She went back and forth from La Jolla to Seattle. She lived up here. And we so carefully documented everything was normal. Complement, the contact system, kininogen cleavage, between attacks, during attacks. And gradually over time, over years, she only became abnormal during an attack. And then a few more years passed, and she looked like a usual acquired. She was abnormal all the time. And so that really has made me very loath to be too dogmatic about acquired C1 inhibitor deficiency. And I always worry about missing the diagnosis in that population. And I don't have an answer to that.
There's some older literature around acquired C4 deficiency and the clinic, autoimmunity related to that. What's your experience with that in the sort of larger population?
Acquired as opposed to hereditary?
Developing an acquired C4 deficiency because of the underlying C1 deficiency and leading to lupus particularly. Is that something you think about in the population?
So usually in the C1 inhibitor deficient patient where they do have an acquired C4 deficiency, there are autoimmune consequences. It tends to be, the way I've always looked at it, and this is straight out of Chaim Brickman and Mike Frank's results, that it's like if you take their genetic background and susceptibility, it just enhances whatever they were at risk for. It tends not to be severe lupus or severe autoimmunity, but they manifest some symptoms of it.
And does that get better with C1 inhibitor?
I have no idea if that gets better. It's rare enough that it's been hard for people to just pick out that association, much less see whether it improves. You would think it would get improved, right? Because like with the subcutaneous, you normalize the C4.